I'm just going to wait a moment to let everyone join. So just your audio is working. We're just waiting for everyone to join. So stand by and we'll get started in just 1 minute. Okay, welcome everyone. Welcome back. Thank you so much for joining us in this session to learn more about the concept of palliative care. I would like to remind everyone to use the Q&A feature for questions. So your speaker for this session this morning is Dr. Addie Patterson. Dr. Patterson joined the faculty at the University of Florida in 2017 as an assistant professor in the Movement Disorders Division. She serves in the role of Associate Program Director for the Neurology Residency Program. Dr. Patterson is originally from Columbus, Ohio. She attended the University of Dayton, where she graduated with a BS in biology. And during this time, she developed an interest in holistic wellness, which led her to pursue a degree in osteopathic medicine. She attended Ohio University, where she obtained her DO degree in 2011. She completed her internal medicine internship at The Ohio State University in 2012, and she completed her neurology residency at the University of Florida in 2015. Dr. Patterson received the Program Director's Award for Academic Excellence during all 3 years of her neurology residency, and during her final year, she served as chief resident and received both the Society of Teaching Scholars Outstanding Resident Teachers Award from the UF College of Medicine and the Kenneth M. Heilman Award for Excellence in Research. Her residency was followed by a 2-year fellowship in movement disorders at the University of Florida from 2015 to 2017, during which she was awarded a grant from the Smallwood Foundation and received the Resident Teaching Award. We're so grateful that you're speaking with us and for us today. So welcome, Dr. Patterson. We look forward to hearing from you.
Hi, thank you so much, Erin. So I assume everyone is able to see my slides, so I will go ahead and get started. Got my screen situated here. Okay, so I'm going to be speaking to you guys today about palliative care in Parkinson's disease. I want to take a moment to thank you guys for inviting me to give this talk. I think it's a really important topic and possibly something new that you guys haven't heard much about in the past. It's really an emerging field within movement disorders and Parkinson's care. And I'd like to thank the Houston Area Parkinson's Society for having me. So what I'll talk about today is the concept of palliative care in general. What is it? How it could be relevant for Parkinson's disease? What does the research say about it? So is it actually helpful? Has it been tried? And what it might look like in your care. How might it be different than the standard care that you're receiving, and how might it be incorporated for you? And then we'll have some time at the end. I plan to talk for about 40 minutes, and we'll have some time at the end for any questions that you might have. So what is palliative care? Palliative care is sometimes referred to as supportive care, so you may also know it by that name. And like I said, it may be a new concept to many of you. It really has its roots in cancer care. And so there are a lot of misconceptions about what it means to receive palliative care. So I hope to kind of explain a little bit more about what it is today so that we can dispel some of those misconceptions. And I also want you to understand what it is because it has a very important role to play in neurologic diseases. So this is a quote from Steve Pantelot, who is an MD and a professor of palliative care at UCSF in San Francisco, and he describes it in this way. So palliative care is about living as well as possible for as long as possible. And so when we really break that down, we already do a great job of trying to help our patients with Parkinson's live as long as possible. So what's different here? The difference is really focusing on living as well as possible during that time that we have. The World Health Organization is also very invested in palliative care, and they define it in these many aspects. So palliative care is a mode of care that enhances quality of life. It offers support to help patients live as actively as possible. So focusing not just on longevity, but quality of active life. It offers support to families and not just patients or people living with Parkinson's and other diseases. It provides relief from pain and other distressing.
So if you want to come over here.
It provides relief from pain and other distressing symptoms, not just, for example, in Parkinson's disease, the motor symptoms of Parkinson's disease, such as tremors and stiffness. It addresses psychosocial and spiritual issues, which is, I would argue, not a typical component of Parkinson's care. It is applicable early in the course of illness and in conjunction with therapies intended to prolong life or prolong function. So this kind of hints at some of the misconceptions that exist around palliative care, is something being available only at the end of life, or something that is an instead of treatment in either or situation rather than an additional therapy. And then it affirms life, but it also introduces the concept of dying as a normal process. It acknowledges that, and it helps people plan for that in their future. So what is palliative care not? So it's not giving up on patients or doing nothing. In fact, it's the opposite. As I mentioned, it's really complementary, and it's an additive therapy to the current standard of care. So if you receive palliative care, you're typically receiving something extra on top of what you typically receive from your medical team. It's not the same as hospice. So hospice is actually part of palliative care, but it's only a very small part. So palliative care can be employed throughout a person's course of illness, and hospice is just a very small part for patients who are in the last 6 months of their life. Palliative care is not euthanasia or death squads, as ridiculous as it sounds. That that is sometimes a misconception that people hold. So that is not part of any aspect of palliative care. In a few states, there is something that's called medical aid in dying, and that does exist. But that is not something that's legal in Florida, where I practice, or in Texas, and it is not at the core of palliative care. Palliative care is not only for the imminently dying. So as we'll talk about during this presentation, it's really a mode of care that can be utilized throughout the course of Parkinson's disease. And it's for any disease. It's not just for cancer, even though that's where it has its roots. And also, it's not something just to be done or provided by palliative care specialists. It doesn't necessarily even mean seeing a different doctor or a different team. It can be provided in many different scenarios, and it takes multiple forms. So the forms that palliative care can take are, number one, an approach or a philosophy of care, which can be incorporated by your current care team, or it can be even a philosophy that's embraced by an individual person living with disease. It's something, at the end of this presentation, you can say, hey, I don't know how much palliative care my clinic provides, but I would like to share with my doctor that this is a philosophy that resonates with me, and it's something that I'd like to incorporate into my care. It's a skill set. So it's something that healthcare providers can be trained in and incorporate into their everyday practice, regardless of what type of healthcare practitioner they are. It is also its own medical specialty. So there are doctors who complete their training in internal medicine or oncology or neurology, and then they actually spend another year doing a fellowship and become board certified as palliative care physicians, and then do this as a full-time job potentially. So they can serve as consultants for patients with Parkinson's disease. And then also, palliative care is a public health goal. So like I said, the World Health Organization and other national and international organizations recognize that palliative care is an important aspect of healthcare, and thinking about it as a public health goal enables the structural supports needed to make it happen. For example, making it a public health goal allows for training in palliative care to be part of medical school curriculum, residency curriculum. It ensures that palliative care teams or hospice is available in hospitals. It ensures that hospice is a covered health insurance benefit for Medicare, and so on. So palliative care can be thought of as a three-legged stool. And so this concept is actually something created by Kirk Hall, who is a Parkinson's patient and Parkinson's patient advocate. And he suggests that in order to provide comprehensive palliative care and to do so in the most impactful way, it requires a multi-pronged approach with incorporation of all of the palliative care philosophies and modes. So the first leg of the stool is palliative care specialists. So as I mentioned, these are physicians who have done an extra additional year of training in palliative care. And they're very important, but they're very rare. So I just looked up the statistics on exactly how many of these physicians exist in the US, and there are only about 7,000 certified palliative care physicians in the US. So for reference, you may think it was difficult to find a neurologist or that a neurologist is rare, but there are actually 3 times as many board certified neurologists as there are palliative care physicians. So this means about 1 palliative care specialist for every 20,000 older adults who may have a life-limiting illness. And not only are palliative care specialists in relatively short supply, but as I mentioned, they also come from many backgrounds. So many of them do not have training as neurologists or don't have a background in neurology. They're not familiar with Parkinson's, so they can't be effective as the only leg of the stool. So the second leg of the stool is community and disease support organizations. So examples of this would be the Parkinson's Foundation, the Houston Area Parkinson's Society. I think all of you in attendance here today already know the value of these community support organizations, but they also have an important role to play in connecting patients with community resources for palliative care. And then the third leg of the stool is really primary care providers and non-palliative care specialists that are familiar with the disease that you have. So this would be your neurologist or other members of your Parkinson's care team, such as a rehab specialist, PT, OT, speech therapist, maybe a social worker on your care team or in your community, a nurse, etc. So Parkinson's, as you all know, is a really complex disease that requires very specific knowledge in order to anticipate the trajectory, but also to manage your likely nuanced Parkinson's symptoms. So this is a nice table that demonstrates exactly how palliative care complements the standard of care. So on the left, we have, what is the focus of typical standard care and how is palliative care different or additive? So first, standard care focuses on disease-related medical symptoms. So in the case of Parkinson's, that's typically motor symptoms and medications for your motor symptoms. Palliative care would focus on the total pain of serious illness, including not only the physical, but also the psychosocial, spiritual, and practical challenges of living with Parkinson's. Standard care focuses on improving your physical health, whereas palliative care focuses on improving not only physical health, but overall well-being and reducing suffering. Standard care prolongs life, and palliative care affirms and values life while planning for the inevitable decline of health and the end of life. Standard care is patient-focused, and palliative care is focused on the person living with illness, but also their family and their support system. Standard care employs variable use of teams. Many of you, if you're receiving your care at a Parkinson's Center of Excellence, probably are used to a team-based approach, but not every disease process, not every person has access to team-based care in standard care. And in palliative care, this is frequently used, this multidisciplinary team approach. So now we've talked a little bit about what palliative care is and how it may differ from standard care. Let's talk next about, is palliative care actually needed in Parkinson's? So there have really been two studies looking at this to date, two major studies, and these are often cited as the impetus for trying to implement some of these modalities in Parkinson's care. So the first one is a 2017 paper, which was written by the person I mentioned before, Kirk Hall, and other members of this Parkinson's Patient Advisory Council. And they suggested that there is certainly a need for palliative care in Parkinson's disease for multiple reasons. And I put the link there, and I think that you'll have access to these slides if it's something that you're interested in reading for yourself. And then there was a 2018 study that was essentially a needs assessment in palliative care, and it enrolled 90 patients with Parkinson's and 47 patients with advanced cancer. And what they found was very surprising. And it was that Parkinson's patients had similar or higher levels of palliative care needs when compared to patients with advanced cancer. And so I think that's really a shocking statistic and has really been the motivation for trying to implement some of these modes of care in diseases like Parkinson's. So why do people with Parkinson's have greater palliative care needs? So what are the relevant issues? In Parkinson's disease, people tend to have not just motor symptoms, but non-motor symptoms, which can be quite burdensome. Pain is a significantly often reported symptom. Fatigue is a commonly reported symptom. Depression, cognitive impairment, psychosis, anxiety, many burdensome non-motor symptoms exist. Patients with Parkinson's can experience demoralization and a lot of spiritual challenges. So people live with Parkinson's for a lot longer than people tend to live with advanced cancer. And it really affects who they are, what they do in their life. It can be impactful on careers. It may affect, what you're able to do with your retirement. It may affect a lot of your plans. And so there are a lot of challenges in the psychosocial realm that arise in Parkinson's that may be a bit different than diseases that have a shorter trajectory. Along those same lines, there are greater caregiver demands and burden in the case of Parkinson's disease compared with other illnesses. So similarly, if you're living with Parkinson's disease for several decades, and you may have high caregiver needs for several years of your disease process. And so that increases the burden and demand on caregivers and care partners. Parkinson's disease also has a very high variability in the prognosis, or what to expect over the course of the illness and what will the time frame be. And so this leads to a lot of stress, and it leads to difficulty in your healthcare team letting you know what to expect, because we don't always know. End of life care can be complex in Parkinson's disease, and there are high rates of complex bereavement, because even once the person with Parkinson's has passed, oftentimes the caregiver and family have become so embedded in the caregiver role that the grief process is quite a bit more difficult than in other diseases. Palliative care also helps to address what really matters to people living with serious illnesses. So this information came from interviews done of people living with serious illnesses, and what they really said was clustered into categories. So what really matters? Family, spending time with family, knowing that their family will be supported throughout the course of their illness and once they're gone. Integrity and dignity. So really being an asset to the world right up to the very end of your life. Having control and being able to make choices, even though they may be limited beyond what you originally thought might be possible. Having a roadmap for the future. So knowing where you are now in the course of your Parkinson's and what's ahead for you so that you can anticipate. Of course, symptom control is important. As we talked about earlier, there can be a lot of really difficult to manage symptoms. And then joy. So finding opportunity to still participate in the activities that you love, making connection to other people, to family, to nature, and continuing the rituals and activities that you previously enjoyed. So this slide illustrates that not only is palliative care needed, but it's needed from the time of diagnosis until, or really even beyond death. So I think most of you all probably remember being diagnosed with Parkinson's disease, and you see the spike here right at the time of diagnosis. I mean, there's a huge amount of psychological distress and grief that comes from being diagnosed with this disease. How is it going to impact your life? What does the future hold? You know, is this going to shorten my life? Will I die of Parkinson's? How long will I be able to work? Am I going to be a burden on my family? There's a lot of distress right at the very beginning. So it would be a mistake to think of employing palliative care only in those last 6 months of life or in those last days of life. It's really something that has a role throughout the many, many years that a person can live with Parkinson's. So we talked about at the time of diagnosis, but then there are also really kind of predictable milestones in the course of Parkinson's disease where distress for the person with Parkinson's or for family members or care partners really predictably increases. So that would be, for example, when a person is no longer able to safely drive, when a person starts to require assistance with some of their activities of daily living, and then when they do start to decline as they do approach the end of their life. So we've established now that Parkinson's is a potentially needed addition in Parkinson's disease care. This was, accepted by the Parkinson's community. And so a trial was able to be done, a clinical trial to look at actually implementing palliative care compared to standard care in Parkinson's disease to see if it actually turned out to be effective. So this was a multi-site study between the US and Canada. So there were sites in Colorado, Rochester, New York, San Francisco, California, and throughout Canada. And it showed that palliative care improved several key aspects of life with Parkinson's. So number one, overall quality of life. Number two, caregiver burnout. Number three, Parkinson's symptoms. And number four, the completion of advanced directives. So I want to walk you through what they actually did. So in this study, half of the patients got standard chronic care for Parkinson's disease. And at these centers, as you can imagine, it was pretty high quality care for Parkinson's disease, probably quite similar to what you receive. So the neurologist was in charge of managing the Parkinson's motor symptoms. So tremors, stiffness, slow movements, gait and postural changes. They made adjustments in Parkinson's disease medications for, dyskinesia wearing off. They addressed non-motor symptoms as they came up, but it's listed here as plus or minus because it was not assessed in a regimented way. Then the patient continued to receive care from their primary care provider who managed all of their non-Parkinson's related illnesses, including whatever medications were necessary for, diabetes, acid reflux, et cetera. And then as it came up, they may or may not manage things like nutrition and weight loss. And then patients were able to access other resources if they sought these out on their own. So support groups, church, family, maybe a lawyer for advanced care planning and things like that. So they really had variable access to caregiver support, advanced directives, and any kind of spiritual needs. So this was kind of the control group. And so, as you probably know, or as you probably experience, when you see your doctor and your care team now, you get pretty good motor symptom control, pretty good non-motor symptom control, especially if it's for issues that you brought up in the clinic, but maybe you go and not every single thing that you've read about as being a part of your Parkinson's gets addressed. And then the teams really didn't do much in the way of advanced care planning or discussion of end of life or managing end of life symptoms. There wasn't necessarily much done for caregiver support or addressing psychosocial and spiritual needs. So that's a standard of care. And I think most people would agree that's probably pretty similar to what they experience now. So the intervention group received this palliative care interdisciplinary model. So the neurologist still managed the motor symptoms. The primary care doctor still managed the non-Parkinson symptoms. And then instead of the neurologist and the primary care provider being responsible for non-motor and nutrition, that was kind of lumped into the palliative care team's role. So what did the palliative care team consist of, and what did they do? So a palliative care physician on the team, in this case, they were all neurologists with some additional training in palliative care, addressed the non-motor symptoms in a systematic way. So they used checklists and questionnaires to do that. They addressed the predicted prognosis for that person with Parkinson's. So they told them, where they thought they were in the course of their Parkinson's disease and what they could expect going forward from that point. There was a nurse who reviewed nutrition, who assessed for home care needs and helped patients and families complete their advanced directives. There was a social worker who screened for and provided caregiver support and resources, screened for financial needs. And then there was a chaplain actually as well, who provided screening for spiritual needs and grief. And they provided counseling when those needs were identified. And so how does this stack up to standard care? So it improved care in multiple areas. So patient quality of life was improved, caregiver support was improved, non-motor symptoms were better controlled, grief and other difficult emotions were better dealt with, spiritual well-being was better dealt with, advanced care planning was more likely to be completed, end-of-life care improved, and healthcare utilization I mentioned because what that means to me is that it wasn't necessarily more expensive because patients maybe didn't go to the hospital as often or other things like that. So this may be, although it takes a lot to create a team like this, it may be a financially feasible model because of reduced healthcare utilization in other areas. So I also want to take a moment to talk about why advanced care planning is important. So to many people, it may not be exactly apparent how that actually translates to a person's care or quality of life at the end of life. And so statistics show that currently only 4% of people with Parkinson's ever use hospice care at the end of their life. And almost half of patients with Parkinson's die in a hospital. And most people in any disease say that their goal is to die at home. So it's not that dying in a hospital is bad, but it wouldn't be the assumption that 50% of people would actually want to die in a hospital. And when they looked at those people who did die in the hospital with Parkinson's, 97% had actually never had a goals of care conversation about what they actually wanted prior to their death. So I think although advanced care planning may seem kind of like a checkbox, it's actually really important in giving a person the opportunity to say what they want at the end of their life. So the study also interviewed patients and care partners about their general thoughts on the care they received during the study. And the interviews suggested that overall the care partners felt less burdened, their anxiety was a lot better, and their own spiritual well-being was a lot better than compared to standard care. And both patients and care partners felt more seen, felt more heard, felt more understood by their healthcare teams. And they really felt they had a roadmap to prepare for the future and make better decisions for today. So everyone deserves a palliative care approach. How do we implement it? So as you can imagine, integrating palliative care to the level that they did in this study really requires a highly trained healthcare team, requires time, requires personnel, monetary resources. And so building a dream team like this, at every center for Parkinson's across the country that exactly mirrors the team in the study is probably not the fastest or most effective way to get palliative care out to the most people living with Parkinson's. So the good news is that Despite that challenge, the Parkinson's Foundation and other organizations have really embraced the concept. And so they've entered into an innovative partnership with the physicians involved in this study. So Dr. Benzie Kluger, the Parkinson's Foundation, a grant from the Picori Foundation, which is the Patient-Centered Outcomes Research Institute, to bring palliative care to the 33 centers of excellence. So in the coming years, each center will be receiving palliative care training for their staff, and they'll be tasked with implementing the 5 specific areas of palliative care that were most impactful in their previous study. So the 5 pillars are annual advanced care planning conversations, so having those conversations on an annual basis with you. Number 2, a systematic assessment and management of non-motor symptoms. Number 3, recognition and support for emotional and spiritual concerns. Number 4, routine assessment and support for family care partners. And then number 5, timely referral to specialty palliative care and hospice care. So I think we have a few minutes left. So I'd like to talk about next how these goals might be implemented and what that might look like for your Parkinson's disease care. So advanced care planning is number 1. So that's really about setting a roadmap for the future. So advanced care planning is one of those concepts that means many things. So on this table here, I have listed all of the aspects of advanced care planning. So those are setting goals of care, planning for the future, advanced directives, and code status. So these are all part of advanced care planning, and I want to walk you through what they mean. And it kind of goes from most broad to most narrow or specific. So goals of care is literally, what do I want for my care and why? So examples of my goals: I may want to cure my disease. My goal may be to prolong my life, or my goal may be to maintain my function. I may want to just support my loved ones for as long as I can. My goal may be to obtain some relief from my symptoms, from my suffering. I may want to accomplish a milestone. So maybe I have an upcoming birth of a grandchild, or I want to attend my, granddaughter's graduation from college. Or maybe my goal is to make peace. Maybe I need to make peace with family or friends, make peace with God before I pass. The next rung in advanced care planning is a roadmap. So certain events and decision points might come up in the course of any illness, including Parkinson's. So it's helpful to plan. So this is really just thinking through specific scenarios and discussing with your family and your doctors what you might want in the future. So I'll give you an example. So this is something that could happen to any of us, right? Our heart could stop tomorrow. And how do we think about that scenario? So if a healthy 20-year-old is walking down the street and their heart stops, it would be a medical emergency, right? In the case of an ill 92-year-old, if their heart stops, then we'd see that as the end of their life. So for advanced care planning, you could kind of think about yourself and how you would conceptualize that scenario for you. So maybe if you are 45 and you've had Parkinson's for 2 years, you may put yourself in the first category. And if you are 85 and you've had Parkinson's for 15 years, you may put yourself in the second category, or maybe not. So this is part of advanced care planning, is to think about, where am I now? And where do I put myself on this continuum with regard to some of the events that might happen? So if my heart stops, if I can't breathe on my own, if I were to need a feeding tube to prolong my life. So those are some examples. Next rung is the advanced directive itself. So how can I tell others what I want in the future? So you can say it, that's part of advanced care planning, but the advanced directive itself means the forms. So you can fill out a healthcare proxy that is designated who would speak on your behalf to communicate what you would want if you cannot speak for yourself. A durable power of attorney for healthcare, similar, a living will, etc. And then finally, the very, very most specific rung on the ladder is the code status itself. So these very nuanced or very direct actually questions. If my heart stops working, what do I want? That's my code status. Am I do not resuscitate, or am I full code? So these questions or these concepts coming up on an annual basis with your healthcare team. So number 2, systematic assessment and management of non-motor symptoms. So as we talked about before, as part of standard care, most likely a lot of these issues are already being assessed and managed by your neurology team. But instead of allowing them to come up naturally, there may be more rigorous screening. So there may be a detailed questionnaire that you complete about anxiety and depression at the beginning of your visit. There may be something like that your team would do. So for example, if they identify anxiety or depression, they may offer you counseling or medication for your symptoms. If your team identifies apathy or loss of motivation, they may help you set a schedule for your day so that they can help you make sure that you incorporate some exercise, which we know is so important in Parkinson's disease. To screen for dementia, they may do some brief cognitive testing on an annual basis. And if they do identify dementia, that might allow your healthcare team to give you a little bit of guidance on what to expect for the future and how to adapt your home environment to best compensate for that. They may screen you for hallucinations and delusions, seeing things that aren't there and believing things that may not be true, which is typically assessed, and if it's sufficiently problematic, managed with medications. But it tends to be something that patients might be embarrassed about or hesitant to bring up. So systematically screening for it can be quite impactful. Fatigue. So your team might screen for fatigue. And if that's something you experience, they might ask you a little bit more about your sleep. They might ask you a little bit more about depression, or try to get to the root of why you're experiencing that fatigue and make adjustments accordingly. Pain. Similarly, if that's something that you report, your team might try to figure out, is it really due to your Parkinson's, or has your Parkinson's disease caused some secondary orthopedic issues? And what's the best way to intervene for that? Do you need more physical therapy? Do you need to be referred to someone who can do an injection for you? Things like that. And then so on and so forth with the additional symptoms listed on the right: constipation, urinary incontinence, vision changes, swallowing problems, weight loss, etc. So number 3, recognition and support for emotional and spiritual concerns. So this one, I think will probably be handled differently at different centers, but your healthcare team might start to ask you more open-ended questions to determine whether you're struggling in this area. So are you struggling to integrate meaning and purpose in your life? Are you struggling to connect to others, to connect to yourself, to connect to your previous passions of art, music, literature, nature? They might ask you questions like, how is Parkinson's affecting your life? How is it affecting your loved ones? How are you coping with this? What are your biggest concerns right now? What about for the long term? What gives your life meaning? What makes you happy and brings you joy? Where do you find your strength in difficult situations? So if it seems like you're struggling with something in one of these domains, they may seek the expertise of a social worker. They might enlist the help of a psychologist or a chaplain, either at your clinic or out in the community. They might help you just remember that you draw your strength from, support in the community, support of other people with Parkinson's. Maybe the pandemic has reduced your ability to connect with other people with PD. And so maybe they'll suggest to, reconnect with a Zoom-based support group, something simple. But I think a lot of these questions don't typically come up. So you might see your care team asking you some different and more unique questions than what you've experienced in the past. Number 4, routine assessment and support for care partners. So I think what most clinics typically do is if they recognize distress on the part of the care partner, they take action and connect you to social work and connect you to resources in the community. But what this might look like would be actually having every care partner complete a questionnaire. So this is an example questionnaire called the Zaret Caregiver Burden Inventory. And typically that's a 12-question questionnaire. They added 2 questions to address some lesser discussed potential issues that are more specific to caregivers of people with neurologic disease. And so this could be given to the care partner and then addressed more systematically. So what we know about caregivers with Parkinson's is that they do tend to experience a lot of distress, especially if the person with Parkinson's has a lot of mood-related symptoms themselves, so depression or anxiety, if they have greater spiritual distress, if the quality of life of the person with Parkinson's is lower, if their Parkinson's symptoms are more burdensome, if they have psychosis or dementia, and if they're interacting a lot with the healthcare system, if they're, frequently visiting the emergency room or being hospitalized, or if they have home healthcare needs and there are a lot of other people coming in and out of the home. So the questions on this caregiver assessment would be things like, for the care partner, do you feel like you don't have enough time for yourself? Do you feel stressed by caring and other responsibilities? Do you feel angry about your role as a caregiver? Do you feel like caregiving is having a negative effect on your relationships? Do you feel strained? Do you feel that your own health has suffered? Do you feel that you have a lack of privacy or a lack of a social life? Do you feel that you've lost control of your own life? Do you feel uncertain about what to do in your role as a caregiver, or you feel that you should be doing more, or that you could be doing a better job? And then the 2 questions I mentioned that were added specifically for Parkinson's are you experiencing physical aggression towards you or others? And are you experiencing sexual aggression or unwanted sexual behavior towards you or others? So these would be important things that would flag your healthcare team to know that the care partner is struggling, and that might lead to increased interventions. And finally, number 5 is coordination of specialty palliative care or hospice. And so specialty palliative care means that you need to be referred to that person who has done specialized training in palliative care. And why might that be the case? Maybe if you have really difficult non-motor symptoms that your neurologist is out of ideas on how to manage, or if there's a difficulty in making one of those complex decisions for your advanced care planning, things like that. So this would involve your clinic really forming partnerships with palliative care specialists in your community and recognizing when their help is needed. And then it also means identification of patients who are likely in the last 6 months of their life, so that they can be offered a greater level of support at the end of their life through hospice care, if that's something that they're interested in. So I'll conclude my presentation there. In summary, what we talked about today is, what is palliative care? How can it be helpful in Parkinson's disease? What does the research say about it? And how might it actually be implemented in your Parkinson's care? And so I'd like to thank again the HAPS for having me talk today, and I'll leave some time for questions.
Okay, thank you so much, Dr. Patterson. I think that this is such a great topic. As a social worker, we do a lot of talk about palliative care, probably not as obviously as we should. It's a little more subtle. And I think people, it's a big paradigm shift for people to kind of understand that palliative care is something that can start at time of diagnosis and doesn't mean end of life care. And a lot of these concepts are things, even when we talk about advanced directives, things that all of us should be implementing as part of our just kind of daily life responsibilities that we should take care of. So I know it's a little bit different as you interpret and hear this stuff as a person with chronic illness. It might be a little bit scary, but I think that the purpose of this whole presentation is to try to help reframe this concept and alleviate some of the fear that's associated with it. So with that, we've had some good questions here, and I'm just trying to go through and look at them. And so since palliative care specialists aren't widely available, how can care partners who have interest and abilities gain the knowledge and skills to provide effective palliative care for loved ones? Or is there one great resource that people can reach out to?
So there are many great resources, and actually because the Parkinson's Foundation has really embraced this, the importance of the concept of palliative care, they are starting to build a lot of programs for direct access. So some caregiver training programs that are available on the Parkinson's Foundation website to talk about, common challenges in caregiving, how to build a support system in your community, how to look for home health care, for example, how to connect with palliative care agencies in your community. So that's one place I would definitely start if you haven't, is on the Parkinson's Foundation website. And like I said, this is something that all Parkinson's centers of excellence will be rolling out in the coming years. So I think a lot more will be kind of provided by your clinic in the future.
Okay. And what about first steps that should be taken? If you're new to the diagnosis, this person says they're new to the diagnosis. So what first steps in palliative care can be taken for someone who's newly diagnosed?
Well, so I think most often when a person's newly diagnosed, what happens? So your doctor says, okay, do this, do this, do this. Okay, you've got Parkinson's. We'll come back in 6 months and, here's some Cinemet. And there's really not that opportunity to say, to experience that gut punch, to acknowledge it for what it is and how impactful it really is. So I think the most important thing is to really take a step back once you've kind of accepted the idea that you have Parkinson's, and really grieve that change from what you thought was going to be your future and what now may be your future. So instead of just kind of skipping that step and saying, okay, I've got Parkinson's, I've got to exercise, I've got to take the Cinemet, I've got to figure out how to take medicine 3 times a day, really pausing and acknowledging the impact of that and thinking through those questions about, how is this diagnosis, or how does the news of this diagnosis feel to me? Why is this making me upset? What am I most worried about? And that can also help you set the agenda for your next visit with your doctor, because you may have a different idea of what Parkinson's is and will mean for you than what your doctor believes it will mean for you. So kind of just taking a pause and really letting it settle in and not trying to jump those difficult emotions.
Okay, thank you. I think I've kind of tried to combine some questions here, but so how far off do you think we are from, palliative care becoming a more standard practice? Do you think that this is a few years off? Do you think this is a decade off? And for those places that are kind of embracing palliative care or kind of weaving palliative care into it, is this something that insurance also acknowledges and is on board with?
So insurance is on board with it. So that's the easy part. How widely available is it, and when will it become widely available is more difficult to answer. So in terms of being available in the format that it was provided in that study, it's really only available at a handful of centers across the country. So that is rare. And that's a problem. And like I said, it's really not feasible to think that every center is going to be able to provide that, because there just aren't the people to do it. But that's why the field of neuropalliative care has kind of come up with this concept, or embraced this concept of primary palliative care, which means training each neurologist to actually provide many of the aspects of what's necessary to incorporate palliative care for their patients. And so that, I think, is the most promising way to get this out to people. And there are changes that are happening. So like I mentioned, in terms of societal support for this and being a public health goal, palliative care is being taught to medical students right now. It was not being taught to medical students when I was in medical school, 15 years ago. It's being taught as part of neurology residency training programs now. It's one of the new milestones that graduating residents have to meet. And I think some of these discussions on advanced care planning are being reimbursed now by Medicare and insurance. So your doctor doesn't have a disincentive to spend that time with you. They get reimbursed for their time to discuss these things. So there are some positives, but there is some There's probably, my crystal ball, I would say in 5 years, the landscape will look a lot different, but in 1 year, it probably won't, probably needs a couple years time.
Okay, thank you for that. Well, we have completed our time for this session. Clearly, I think we could spend so much more time talking about this concept, talking about the importance of palliative care in Parkinson's. And really, I think there's a lot more in the future ahead of us in terms of, embracing this dialogue and moving things forward. And I know a lot of the focus of what we do here at HAPS has that kind of palliative care, kind of flavor to it as we look at quality of life and we look at point of diagnosis and beyond, and how folks get prepared for things. But clearly there's a lot more that we can talk and learn about with this concept. And we look forward to seeing how things evolve locally with the Center of Excellence Palliative Care Program here and beyond. So thank you, Dr. Patterson, for your time. And everyone will, as we leave this session, will need to make sure that you join us for the next session, which is treatment in PD, what's new and what's coming soon. So again, thank you, Dr. Patterson, for joining us. We're excited to have you as a speaker this year, and we will see everyone at the next session. Bye-bye.
Thanks everyone for attending.